Hi and welcome everybody. We're just letting people enter the webinar tonight, so we'll give it a minute. If you are joining as a French participant, you can see the numbers on the screen to dial in for hearing this webinar translated in French tonight. So if you haven't already and you prefer to listen in French, please call into the numbers on your screen. My name is Antonella Scali, and I'm the Executive Director of the Canadian Psoriasis Network, or CPN. And again, I'd like to welcome everybody to our webinar tonight that will focus on conditions associated with psoriasis and psoriatic arthritis. For those of you who are new to CPN, we're a national not-for-profit organization dedicated to improving the lives of people in Canada who live with psoriasis and psoriatic arthritis. And we do that in part through educational events like this one. So if you're just joining us for the first time, welcome. For those of you who are joining us for the first time, I just want to remind you that you are in listen-only mode for the duration of the event on the webinar, because we are recording the session tonight. If you are calling into our French line, I ask if you can please mute your line throughout the duration as well, just so that, again, we can hear clearly on the recording. I do want to go over some housekeeping just before I turn it over to our presenters, but I'd like to begin. We are a national organization, so I do want to acknowledge the Indigenous peoples of all the lands that we're on today. While we meet today in a virtual platform, I'd like to take a moment to acknowledge the importance of the lands which we all call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So I do, in addition to the keeping yourselves on mute, I do want to also remind you that the recordings will be available after the session in English and French. So we'll be sending that around. So if there's anything that you missed, you're welcome to watch the recordings once they're posted. I do also want to remind everyone that, like all of our sessions, the information that we're talking about this evening is general only, and the presenters are speaking from their own clinical and research expertise and perspectives. So if you do have any questions tonight, we invite you to please put them in the chat. We'll be doing a Q&A session at the end, but we will, of course, only be answering general questions, and any specific questions you might have about your health would of course, be directed to your doctor. I also want to, of course, acknowledge our sponsors for this evening's event, Novartis. We couldn't put on events like this without them, so we thank you. And I do want to mention that we put on programs like this throughout the year on topics that are of interest to our community. So if you're not a member already, I encourage you to check us out at cpn-rcp.com. You can find other content and webinars that we've done on important topics to our community. And you can sign up to join us as a member. It is free, and stay informed about upcoming events and about information that's important to the psoriasis community in Canada. Tonight's event in particular is really an important issue that comes up regularly in terms of the importance of being aware and kind of knowing what you have to think about when you live with the chronic condition of psoriasis and psoriatic arthritis. People with these conditions are at elevated risks of different comorbidities. So tonight, our speakers, we're grateful to have them to speak about some of the more common conditions that are associated with psoriasis, and most importantly, what you need to know and what you can do about it, and how you can work with your team to be able to know your risks, know how to what prevention you may be able to think about, and how to work with your care team to be sure that you're being screened and considering that whole health picture when you live with psoriasis. So again, please do stay connected. If you're not a member already, we welcome you to join us. And I'm very pleased to, it's my pleasure to turn it over to our first speaker without further ado tonight. We're very lucky to have two excellent presenters, Dr. Mark Kirchhoff and Dr. Lihi Eder, present with us tonight. Dr. Kirchhoff is going to start us off by giving us an overview about associated conditions with psoriasis, and again, some of the more common ones that we have to keep in mind. And then Dr. Eder will take a deeper dive into psoriatic arthritis and cardiovascular abnormalities related to psoriatic disease. So I'm very excited to turn it over to Dr. Kirchhoff as our first speaker, and I'll just give a brief bio for those of you who don't know Dr. Kirchhoff yet. Dr. Mark Kirchhoff is the division head of dermatology in the Faculty of Medicine at the University of Ottawa and the Ottawa Hospital. After receiving his Bachelor of Science in Molecular Biology from McMaster University, Dr. Kirchhoff completed his medical degree and PhD at Western University in London, Ontario. His PhD research involves studies of the signaling pathways important to immune system regulation. He then went on to complete his dermatology residency at the University of British Columbia in Vancouver, British Columbia. Until August 2017, Dr. Kirchhoff was the education director at Queen's University in Kingston, Ontario, where he coordinated and led undergraduate, postgraduate, and continuing medical education activities. He's published over 50 peer-reviewed papers and maintains a keen interest in clinical and bench-to-bedside research. He's been invited to speak at local, national, and international meetings. His clinical interests are varied, and he sees both pediatric and adult patients. Dr. Kirchhoff was recently awarded the Teaching Award by the Dermatology residents at the University of Ottawa. He develops and provides the basic science lecture series for residents in addition to weekly clinical teaching in the clinic and on call in the hospital. He's also an examiner for the Royal College Dermatology exam and a board member of the Canadian Dermatology Association. So it is with great pleasure that I turn it over to our first expert tonight, Dr. Kirchhoff. Thank you so much. I turn it over to you.
Thank you. You can see my slides?
Yes, we can. Thank you.
Excellent. Okay. So I'm going to provide more or less an introduction. This is obviously a large and broad topic, and I just hope to spark interest by presenting some interesting things about psoriasis and how it relates to the skin, the mind, and the body. These are my conflicts of interest. I have given talks for some companies, and I've also done some consulting. I've run a few businesses also, which was not included in my background, but so I've been involved in that. So we'll start with a very simple overview of what is psoriasis. So we believe that psoriasis affects about 1% to 2% of the population, although that can vary. Some countries and some areas have much higher prevalences of psoriasis. Denmark and Newfoundland are examples of places that have higher prevalences of psoriasis. It's believed to occur in a bimodal incident. Basically, that means there are two peaks where we see a lot of new psoriasis developing in people's 20s and in the 50s. That was one's slightly smaller. It's believed to be related to a variety of genes, so it's not just one gene. So it's called polygenetic, and it's an autoimmune disease, so it's an inflammatory condition where your immune system is attacking the skin. And as we'll see in this talk, it can attack other parts of the body as well. It can range from being very mild, happening once in a while, to being very severe, as you can see in this picture right here, where this patient has lots of psoriatic plaques affecting the skin. Often patients will tell us that it flares with triggers. Something will set it off and cause it to get worse suddenly once in a while. It presents with these sharply demarcated red papules and plaques. It has this very silvery white scale, as you can see in that picture that we just saw there. That's sort of silvery whiteness, and that makes it different than a lot of the other rashes that we see on the skin. The scales are often loose. They do come off, and often I will hear from patients that they'll have shedding that occurs in their clothing and on the bedding and in their house. And the common sites that are involved are the elbows, knees, buttock region, scalp, palms, and soles. But you also can have fingernail and toenail involvement. So it's not just necessarily the skin, but you can also see the nails being involved as well. Symptoms that psoriasis patients can suffer with are itching and pain are the two big ones that people feel, but you can also have, as mentioned, the flaking skin, bleeding, redness, and thickened skin. Sometimes it's hard for people to move their hands. If they have psoriasis on their hands and feet, it can be hard to use their hands or feet. Even walking can be difficult for some patients. This is the general distribution, as I alluded to earlier, and where it is. And so this helps us also differentiate psoriasis from other inflammatory conditions. Eczema or atopic dermatitis tends to have a slightly different distribution than this. And we look for those differences when we're assessing patients. I'll show you some pictures of what psoriasis looks like. So as mentioned, it's sharply demarcated. So you can see, here is normal skin right here, and you know exactly that there's a line that separates normal skin from the psoriasis plaques. And so that's what indicates sharply demarcated. And again, the silvery white scale that you can see here, also on the back of this patient right here. You also can have smaller areas and more confluent areas. On the nails, there's a few common things that we see. One is these pits that can occur. So you can have nail pitting. It can be 1 or 2 pits on the nail, or it can be lots and lots of pits, as you can see here. The other thing that we see is yellowing of the nail. You can see there's these yellowish areas here. That's called an oil drop sign. And then we also see separation, so of the nail plate, which is the hard part of the nail, from the nail bed, which is underneath the nail. And that gives this appearance of an increased white area from the edge of the nail. And so that is called onycholysis, and that's the separation of the nail plate from the nail bed. Of course, psoriasis can affect other parts of the body, as alluded to. Having psoriasis around the belly button or umbilicus is a key sign that lets us differentiate psoriasis from other conditions. As mentioned, it can affect the hands and the feet here, sometimes confused for fungal infections. It can be on the scalp, and this can be confused for seborrheic dermatitis or dandruff. Obviously, it can be very inflamed and very itchy. And then, as will be talked about throughout the evening, you can see impact on the joints to the point that it can actually cause mutilation of the joints and deformation of the fingers or the feet. There are variants of psoriasis that I won't get into all of them, but I'll just mention a few of them. So one of the common ones that we see is pustular psoriasis. So you can actually see pustules that form either on the hands and feet, or they can be over the entire body. There's palmoplantar psoriasis that just affects the hands and feet. There's inverse psoriasis where the skin folds are affected. So in the buttock area and the gluteal cleft, you can see that. And as we talked about earlier, there's this nail psoriasis, and the nail psoriasis can be severe enough that you can actually lose nails completely. So what causes psoriasis? Well, as with all complex polygenic diseases, we know that genes play an important role. Many genes have already been identified, but we still don't have a clear picture of all the genes that are involved. We know that if you have one parent, your risk of psoriasis is about 10 to 25%. If both parents have psoriasis, your risk is 50%. So it's not 100%, which indicates that there are other factors involved. And some of those other factors are perhaps the environment, and we'll talk about some of the triggers. And then the immune system. The immune system is very complicated, and it evolves as we age and can change as we age. And so there are different triggers that can be involved, and our immune system itself, by what we're exposed to, can change throughout the course of our life. So really the exact cause of psoriasis is not known 100%, but we know that genes, environment, and immune system are all factors. Some of the triggers that have been identified are climate, skin injury, stressful life events, infection, medications, smoking, and alcohol. The end result of this is that the skin changes. in patients who have psoriasis. So usually skin replaces itself every 28 days. And basically the skin is a multi-layered organ, and it basically starts at the bottom here where there are some stem cells, and then they undergo differentiation, and they slowly change and they migrate up to the top layer of the skin, where eventually they flake off. And that takes about 28 days. In people who have psoriasis, the skin replaces itself every 3 to 5 days. The result is that there is a much faster transition time from the top to the bottom. The skin also gets much thicker, and it gets scaly and red. So those are all indications of psoriasis. Here is just a nice slide to show you how confusing and complicated psoriasis can actually be. So we know that even in patients who have a predisposition to psoriasis, there can be a genetic change. So there's lots of genes here that have been identified. And then we get triggers that can be identified here. So stress, obesity, infection, dust, drugs, tattoos. I've seen patients who've gotten psoriasis in their tattoos. This causes a whole cascade that eventually leads to this chronic recurrent psoriasis where you have a psoriatic plaque. The skin is a lot thicker right here, and there's all this inflammation that's going on underneath the skin. In dermatology, we assess psoriasis through a variety of different measures. One of them is the body surface area. So the more skin surface area you have, the worse your psoriasis is. And an easy way to do this is to look at your hand, and one palm of the hand is 1%. So the number of palms you have equals approximately the number of percent of body surface area you have. A slightly more complicated measure is something called the PASI score, which is a psoriasis area and severity index. So it also takes into consideration the area, but then we also measure the severity. The severity is measured by looking at the redness or erythema, the thickness of the plaques, and the amount of scale. And then finally, we also assess the DLQI, or the Dermatology Life Quality Index. And this is a questionnaire where we look at the impact of psoriasis on the patient's life, and it gives us a score out of 30. Here's just an example of the body surface area to give an idea of what is mild, moderate, and severe disease. So mild, you might have less than 3% body surface area, maybe a little bit on the knees and elbows, but that's about it. Moderate, you start to have larger areas between 3 and 10% of the body surface area. And then severe is when you have more than 10% of the body surface area covered by psoriasis. There are, of course, many celebrities who have had psoriasis. I've just listed a few here. Phil Mickelson, you may have seen, recently won a major golf tournament. He has psoriatic arthritis as well. Leanne Rimes has psoriasis, and to bring awareness, she recently posted a picture on Instagram showing her psoriatic flare and the amount of psoriasis that she has over the body. Psoriasis is also prevalent in history. Many people have had psoriasis historically, and it has impacted historical events. This was an assassination that actually occurred in a psoriatic bath, as you can see here. This is from the French Revolution, and this featured prominently in one of these famous paintings shown here. So now I will move on to talk about a case to give you some indications of what psoriasis can do, how complicated it is, and perhaps get us thinking about how psoriasis can interplay between the body. So this is a real case from one of my clinics. This is a woman in her 60s who presented to my clinic with a history of psoriasis. She was treated many years with topical steroids and vitamin D, and she did very well. She had very little psoriasis, only a little bit on the knees and elbows. 3 months prior to seeing me, she was in a car accident. She experienced a severe flare of her psoriasis 2 weeks after the accident, and she developed severe joint pain as well and swelling of her fingers. And this is an example of what she looked like. I didn't take pictures of her in my clinic, but you can see that she had very, very severe psoriasis affecting large portions of the body. And so it brings up the idea, you know, what happened and how did this happen? Does stress trigger psoriasis? What are the neurological components in the psoriasis pathophysiology? And what role does stress play in inflammatory diseases in general? And if you look at the literature, there's not a lot, but there is some. So this is one of the studies published in 2018, looking at stressful events and its relationship to psoriasis and the onset of psoriasis. And these are all the different studies right here, the references, the number of patients involved. You can see there's quite a significant number. And then the number of patients who report a stressful event before the onset of their psoriasis. 53%, 89%, 70%, 72%, 68%, 35%. So you can see that overall, it's the majority of patients who do report stressful events before the onset of their psoriasis. And then the patients who report stressful events before flares, again, also very high. Same thing that we saw with our patient. Even more interesting is that stress seems to impede the ability to respond to treatments. This is an experiment that was done looking at patients who had high levels of stress versus low levels of stress, and they were given light treatments. And if they had low levels of stress, they had much higher levels of clearance compared to the patients who had higher levels of stress. And so stress control we can consider as a very important component of treating psoriasis. I just wanted to give a very interesting case report that gives an idea of the interplay between the body and the nervous system and psoriasis. So this was a 49-year-old computer operator who was knocked off his bicycle, sustained a posterior dislocation of the right shoulder. And this caused some damage to the nerves in that arm, and the patient did not have a lot of power in that arm. So basically the nerves were disrupted. Interestingly enough, the long-standing psoriasis in the arm that had the damage went away. And so the inability of the nerves to signal properly seems to have affected the psoriasis in that arm. 4 months after the injury, when the nerves regenerated, the power and the sensation in that arm went back to normal, the psoriasis started to appear again. So this idea that the body, as we've seen, is able to influence the skin, in this case, a disease, the psoriasis, is something that seems to be very important. We're also going to now give some information and a few hints on how the skin can impact the body in the other direction. So what is the true medical impact of psoriasis? So this is a study looking at the age of psoriasis patients and controls, and how long they live. And what they noticed is that people with severe psoriasis seem to have a lower life expectancy by about 3.5 years for men, and it's 4.5 years for women. The top causes of death with patients who had severe psoriasis were cardiovascular disease, infection, and cancer. And so it shows us that the skin disease must impact other parts of the body as well. And in fact, I'll just show some of the data, but this is what has been found through a variety of studies, is that psoriasis is actually a multi-system disease. It can affect the eyes, it can have inflammation of the eyes, uveitis, it can cause cardiovascular disease, it can be related to COPD, we'll see much more detail about how it's related to the joints. It can cause depression, fatigue, disturbed sleep, cognitive impairment, as I said, cardiovascular and heart disease in particular, not just the vessels, but the heart itself can be affected. The metabolic syndrome, and this is a very big one, and I will talk about this in a little bit more detail, but diabetes and dyslipidemia can be related. And then you can have autoimmune diseases of other organs, including Crohn's disease. So psoriatic arthritis, just in broad terms, we know is inflammation of the joints. It usually appears within the first 10 to 15 years of developing the skin disease. Psoriatic arthritis prevalence in the general population is 0.5 to 1%, but if you have psoriasis, it skyrockets to between 6 and 42%. So it increases as well with the amount of psoriasis that you have. The more skin disease you have, the more inflammation you have, the more likely you are to have joint disease. So other medical comorbidities, you know, psoriatic arthritis is the most common by far. Inflammatory bowel disease, strep pharyngitis, lymphoma, internal organ malignancies, depression, anxiety, suicidality, COPD, alcohol use, cardiovascular disease, metabolic syndrome, obesity, hypertension, dyslipidemia, diabetes, sleep apnea, and skin cancer. And just to show you how widespread the inflammation is, what they've done here in this experiment is they've taken a psoriasis patient, they've taken a patient without psoriasis. And then they take their white blood cells or their immune cells and they add a dye so they can track where the inflammatory cells basically go in the body. And they found that they can see inflammation in the psoriasis patient in the aorta, in the liver, in the vasculature, in the joints, and of course in the skin, which you don't see in the control patient without psoriasis. We have a way of measuring inflammation as well in the body, the amount of inflammation, that's called the C-reactive protein. So this measures the amount of inflammation. And here on the x-axis is the PASI. So remember, that's a way of measuring the amount of psoriasis and the severity of psoriasis. So these patients along here have worsening psoriasis. And this is the amount of inflammation. So the worse psoriasis, the more inflammation that these patients have. In addition, we know that because psoriasis is an autoimmune disease, people who have psoriasis are at a higher risk of developing other autoimmune diseases. I talked a little bit about inflammatory bowel disease like Crohn's disease, but they also have a higher risk of having rheumatoid arthritis, alopecia areata, celiac disease or gluten insensitivity, systemic sclerosis, and vitiligo as well. So one autoimmune disease seems to predispose you to having other autoimmune diseases. And then this is a very important interplay, the interplay between psoriasis and fat. So we know that psoriasis in the skin produces lots of different inflammatory components. This inflammation actually signals, and you can get increased fat deposition in the body. That fat in turn produces more inflammatory cytokines, and that makes your psoriasis worse. And so it's a feedback mechanism here. The more fat you have, the more predisposed you are to metabolic disorders. And one of those that's related to that is heart attacks. And so patients who have severe psoriasis versus mild psoriasis, they have a much higher degree and risk of having heart attacks, especially at a younger age. So patients who have severe psoriasis in their 20s, 30s, 40s, 50s, and 60s have a much higher level of heart attacks compared to people who have mild psoriasis. That evens out later on as people age, you can see down here, because then obviously there are other things that can cause heart attacks. Metabolic syndrome, which encompasses diabetes, hypertension, increased fats or lipids, and obesity, are all related to severe psoriasis. The more skin inflammation you have, the more likely one is to have these other conditions. Diabetes, elevated as seen, and the odds ratio, or the risks seem to increase with age, and it's up to 248%, I guess you can argue that way, higher in patients who have psoriasis compared to control populations. So really there seems to be a link between psoriasis, obesity, and cardiac or metabolic disease. And we know that the more obesity you have, the more likely you are to develop psoriasis. The more psoriasis you are to have, the more likely you are to have obesity. The more obesity you have, the more likely you are to have cardiac and metabolic disease. Cardiac metabolic disease increases your risk of psoriasis. So really, it's an interplay between these three things. So I think I've shown you conclusive evidence that the body can trigger psoriasis, and that psoriasis can go back and cause all sorts of diseases in the body. So now we're going to talk a little bit about the brain. And we haven't alluded to that yet, but we know that the brain does also respond to some of those same signals that we've seen affect the body. In particular, it's been shown that inflammation, so when you have inflammation down here, skin damage and destruction, and some of these inflammatory markers and some of these inflammatory cytokines, they can circulate and they can go into the brain. And this can actually lead to depression and anxiety. And the brain itself can then release more steroids, which can then cause this loop to develop. So we know that there seems to be an interplay between inflammation and the brain, and particularly in depression and anxiety. So here we see for psoriasis patients versus controlled patients, that psoriasis patients have a much higher level of depression, a much higher level of anxiety, as well as other psychiatric comorbidities. The issue is that patients who have these psychiatric comorbidities tend to have a less desire and less ability to treat their psoriasis. So depression has been associated with a threefold risk of non-adherence to medical therapy. And so if you have poor psoriasis control, you may have worsening depression. That may decrease your likelihood of adherence to medical therapy, which decreases your psoriasis control. And so you have this feedback mechanism that develops, causing worsening of psoriasis and possibly worsening of your depression. There was a recent study that was published about depression itself being a risk factor for the development of psoriasis. And this was published out of the University of Calgary, so it's good to promote Canadian research. So depression has been linked to increased levels of inflammatory cytokines, thereby sharing some of the inflammatory cytokines associated with psoriasis. Moreover, depression is an independent risk factor for the development of psoriatic arthritis, which I'll show you in the next few slides, in psoriasis patients. So the question is, does depression increase the risk of developing psoriasis? And the answer is yes. So they did a very large study. This is thousands and thousands of patients, and they found that depression alone increases your risk of developing psoriasis. So that means that psoriasis causes depression, and depression causes psoriasis. So again, that feedback mechanism is important. So this is one of the first studies to identify the temporal relationship between having depression and then developing psoriasis. The exact mechanisms are somewhat unknown, but this is of course very important. And as mentioned, there are other studies that show this interplay. So this is a study that showed that depression is a risk factor for the development of psoriasis, and a retrospective study in the UK that came after the last one that I just showed you, and that depression is associated with an increased risk of developing psoriatic arthritis among patients with psoriasis. So if you had depression with your psoriasis, you had an increased risk of having joint problems or joint disease later on. So we've really glanced over, but alluded to these connections between the body. As we saw earlier, a stressful event can trigger a skin disease. The skin disease itself can then go on and manifest with many different diseases in the body. As we saw, it can affect obesity. That obesity can cause inflammation, and that inflammation can cause more skin disease. So these feedback loops appear to be very important in disease pathology. In addition, we saw that psoriasis can affect the brain. The inflammation that's in the skin can travel through the body and can impact the brain, causing increased levels of depression and anxiety in patients who have psoriasis. And as we just saw, that depression itself can increase the risk of having psoriasis and psoriatic arthritis. So there really is a connection between the mind, the body, and the skin, and that inflammation seems to be at the central point for this connection throughout the body. And with that, I've just given you a very quick overview and a quick taste of this very complicated disease and how it can affect different parts of the body. And I will take some questions in the next 15 or so minutes if you have any.
Thank you so much, Dr. Kirchhoff. That was very fascinating to get an update of what the research is saying about these connections. And I will also invite people, if you do have questions, to please put them in the chat. And if it's okay with you, Dr. Kirchhoff, we'll do Q&A at the very end with both of our speakers for any questions that come up, because there might be some overlap for both of you. So thank you so much. And again, if you do have questions, please do put them in the chat, and we'll get to them at the very end with both of our speakers. I wanted to also do a quick reminder that if you're listening on the French line, to please mute your phone, just so that we can make sure everyone can hear. And I also want to just acknowledge to Dr. Kirchhoff's presentation that we do have a webinar about psoriasis and mental health that takes a deeper dive, and also provides some information on what you can do if you are experiencing any depression or anxiety, because we know that's a common associated condition. We have some good information on that webinar, so I invite anyone who's interested to check that out. And now I'm so excited to turn it over to our next speaker, who's going to take us into a deeper dive on the metabolic parts of the inflammation connection with psoriasis. Dr. Lihi Eder is our next speaker, and she'll also be giving us some great insights on what we can look out for and what we can do. I'll introduce Dr. Eder. She is a clinician scientist and staff rheumatologist at the Women's College Research Institute and associate professor of medicine at the University of Toronto in Canada. Dr. Eder has a broad background in rheumatology with specific training and expertise in clinical and genetic epidemiology of psoriatic arthritis and cardiovascular diseases in rheumatic patients. She's the director of the Psoriatic Arthritis program at Women's College Hospital and co-director at University of Toronto Cardio-Rheumatology program, an interdisciplinary program that aims to improve the management of cardiovascular comorbidities in the rheumatic patients by developing novel models of care and through research and educational activities. Dr. Eder's research efforts have resulted in over 110 peer-reviewed publications in medical journals, book chapters, and editorials. As a recognized emerging expert in rheumatology, she received a New Investigator Salary Award from the Arthritis Society in 2016, an Early Research Award from the Ontario Ministry of Research, Innovation and Science in 2018. And it's with great pleasure that I turn it over to you, Dr. Eder. Thank you.
Thank you so much, Antonella, and thank you for CPN for organizing this event and inviting me to talk. So, as mentioned, I'm a rheumatologist, but I also am very interested in cardiovascular diseases in patients with rheumatic diseases, and I run a cardio-rheumatology program at Women's College Hospital. So I thought today we could take deeper dive into the relationship between the skin, the joints, and the heart. So, as Dr. Kirchhoff presented very elegantly in his talk earlier on, psoriasis is a chronic inflammatory skin disease that affects about 1 to 2% of the general population, and psoriatic arthritis is an inflammatory disease that affects the joints, the tendons, the spine, and it affects up to 1/3 of the patients with psoriasis, and it can lead to significant joint damage and disability. Now, psoriasis and psoriatic arthritis have sometimes been referred to as an iceberg. So there are things that people can see from the outside, which is mostly the skin and sometimes the joint disease, but there are also many other comorbid conditions or diseases that are associated with psoriasis and psoriatic arthritis that people may not appreciate from the outside, but can affect significantly patients' lives. And these include the metabolic abnormalities, obesity, cardiac diseases, and depression. And we're going to focus today on the heart diseases and their relationship with psoriatic arthritis and psoriasis. So when we're talking about cardiovascular diseases, we are referring to these conditions. So coronary artery diseases are diseases that affect the coronary arteries. They can block these blood vessels that bring blood to the heart, and blockage will lead to heart attacks. Stroke are conditions that are related or affected, caused by blockage of the carotid arteries and arteries that bring blood to the brain. And peripheral vascular diseases are diseases that affect blood vessels in the upper and lower extremities and can cause problems, pain, and the ulcers mostly in the lower extremities in the legs. So many of you are familiar with the symptoms of heart attacks, probably mostly with the Hollywood heart attack style, which is severe pain in the middle of the chest, sometimes causing or radiating into the neck or the left arm. But in many patients, heart attacks and heart diseases may present differently. They may cause pain that is less severe or less acute. The pain may be located in different places, such as the neck or the back. they may present with nausea, shortness of breath, or even sudden unexplained severe fatigue. And these atypical presentations of heart diseases tend to be more common in women, so they may confuse both the patient and the physician because they are really not typical. And although there is not a lot of research, many patients with arthritis have pain that may mimic heart symptoms. So if there is arthritis in the joints in the chest, that can cause chest pain that may mimic this type of pain. So it can be confusing, but in any case of suspicion, it's recommended to see a medical specialist as soon as possible. Symptoms of stroke can be remembered using this acronym FAST. So face, if there is any drooping in the face, arm, if there is any weakness of the arm, difficulty in raising the arm, speech, if there are abnormalities in speech, blurred speech, and if any of these symptoms occur, then it's time to call 911. It's very important to see medical attention as soon as possible. So heart diseases, as has been mentioned by Dr. Kirchhoff, are common in patients with psoriasis and psoriatic arthritis, and in fact, they are the #1 cause of death, similar to the general population, but the risk tend to be higher, and these diseases occur sooner or earlier in patients with psoriasis and psoriatic arthritis. And the risk tends to be around 30 to 40% higher in patients with psoriasis and psoriatic arthritis compared to the general population. So people do not have psoriasis and psoriatic arthritis that are the same age and the same sex. So what links psoriatic arthritis and psoriasis with cardiovascular diseases? So the process that leads to heart attacks, strokes, and peripheral vascular diseases is called atherosclerosis. And this process occurs as a result of accumulation of cholesterol in the blood vessel wall. And you can see this cholesterol accumulates in the blood vessel wall, and this is called a plaque. And when a plaque ruptures, it may cause an immediate occlusion or blockage of the blood vessel, and this can lead to a heart attack if that occurs in the heart. It can lead to a stroke if that occurs in the brain, and it can lead to a peripheral vascular disease, especially if it occurs either it can occur acutely and then it causes sudden onset of pain, or if it occurs slowly, then people may feel pain when they do exercise. And there are a lot of similarities between psoriasis, psoriatic arthritis, and atherosclerosis, which is the process that leads to these heart conditions. We know that psoriatic arthritis is inflammation in the joints, psoriasis is inflammation in the skin, and it is now accepted that atherosclerosis, the process that leads to heart attacks and stroke, is a chronic inflammation of the blood vessels. And studies have shown that there are many proteins and many factors that are produced by the immune system that are elevated in patients who have heart diseases, as well as in patients with psoriasis and psoriatic arthritis. And you've seen this picture just recently by Dr. Kirchhoff. This is a nice image showing this relationship, so I'll skip that one. But we also know that not all patients with psoriasis and psoriatic arthritis are at the same risk of developing future heart diseases. So what are the risk factors? So first, we know that traditional risk factors are important. So by traditional risk factors, I mean age, sex, but also metabolic abnormalities like diabetes, obesity, hypertension. And these factors tend to occur at a higher prevalence in patients with psoriasis and psoriatic arthritis. But in addition to that, we also know that more severe psoriasis and more severe arthritis are risk factors for future development of heart diseases in people who already have psoriasis or psoriatic arthritis. So the larger the body surface area covered by psoriasis, the higher number of joints that are painful or swollen, and the presence of dactylitis, which is this sausage digit that is a very characteristic feature of psoriatic arthritis, is also considered to be a severe type of inflammation in psoriatic arthritis, and this has been associated with a higher risk of developing heart diseases. So how can we deal with inflammation? And people raise the question of whether we treat inflammation, can we reduce the risk of developing heart diseases? And this is relevant not just for psoriasis and psoriatic arthritis, it is relevant for other rheumatic diseases and other conditions that are associated with high levels of inflammation. So this topic has been investigated in mostly in rheumatology, also in several dermatology settings, and it's been shown that some of the medications that we use to manage psoriatic arthritis, rheumatoid arthritis, psoriasis can in fact reduce the risk of developing heart disease in people who use these medications. So one example is methotrexate. Methotrexate has been used for many, many years in treatments of rheumatoid arthritis, psoriatic arthritis, as well as psoriasis. And it's been shown that patients who were using these medications had a 30% lower risk of developing heart diseases. A newer type of medication is a class that is called tumor necrosis factor inhibitors. So there are several medications within this group. This is the first group of biologic medications that's been approved for psoriatic arthritis. It's been used commonly in psoriasis as well. And it's been shown as well that this type of medication is associated with a reduced risk of developing heart diseases in people with psoriasis, as well as psoriatic arthritis and rheumatoid arthritis. So overall, there seems to be an evidence to suggest that controlling inflammation in the skin and in the joints can potentially also reduce the risk of future development of heart diseases. We've further investigated this topic in our clinic, and we've looked at the risk of progression of plaques. And I mentioned that plaques are important because rupture of plaques lead to heart diseases and stroke. And in the clinic, we do carotid ultrasound, which is a very quick and easy way to assess how many plaques are there in the carotid arteries in the neck. So you can see here an ultrasound image, and this is a plaque in the artery. And the other imaging modality that we use is called PET-CT, and you've seen the images of PET-CT where there is an uptake of this tracer, and when it identifies areas of inflammation in the blood vessels. So what we did, we compared patients who were using TNF inhibitors to patients who were not using TNF inhibitors and followed them over time. What we found is that men who were using TNF inhibitors had a reduction in the progression of plaques over time compared to people who were not using these medications. Interestingly enough, we didn't see this change in women. We are not sure if this is due to differences in the way atherosclerosis behaves in men and women. We know that there are differences, or this is related to the fact that women had a lower degree of plaques to begin with, but nevertheless, it does suggest that there is some potential protective effect of TNF inhibitors, especially in men. And we also found that people who are using TNF inhibitors had a reduction in inflammation in the blood, in the aorta, in the big artery that comes out of the heart. Again, this is another support to this notion that treating inflammation is important in protecting the heart. So how else can we prevent heart diseases besides excreting inflammation. So I mentioned traditional cardiovascular risk factors, and there are some risk factors that are considered to be non-modifiable, and it means that we cannot change them. Unfortunately, we cannot change our age, so typically as we get older, the risk of getting these heart conditions becomes higher. Typically men above the age of 45. In women, there is a 10-year delay. Women usually after the menopause, the risk increases significantly. So sex is another factor. I mentioned men usually have a higher cardiovascular risk, but after the menopause, women tend to catch up. And there is also an association between some pregnancy history, so women that had gestational diabetes or high blood pressure during pregnancy are at increased risk of developing future heart conditions. Of course, genetics are important, so there are some genetic factors, and although we don't test genetic factors for heart diseases routinely in our clinic, but we can get a clue from the family history. So we talk about premature cardiovascular diseases in first-degree relatives, so not every family history of heart disease is considered to be significant, so only if it occurred prematurely, so in men before the age of 55 and in women before the age of 65. And finally, ethnicity. There are some ethnicities that we know that there is a higher risk of developing cardiovascular diseases, and this is also likely associated with some genetic factors. And beside these non-modifiable factors, there are modifiable factors, and this is good because it means that there are things that we can change that could potentially reduce the risk of developing future cardiovascular diseases. We talked about metabolic abnormalities, and obesity is strongly associated with psoriasis and psoriatic arthritis. Obesity is very prevalent among psoriasis patients, and it's associated with diabetes, abnormal cholesterol, and hypertension, that all of these are known to be traditional risk factors of heart diseases. And in fact, obesity is now considered to be a risk factor for psoriasis and psoriatic arthritis. There's been several large studies that have shown that higher BMI is associated with future development of psoriasis, as well as the development of psoriatic arthritis. And patients are often asking me or seeing me and asking about what they can do in order to prevent the risk of developing psoriatic arthritis. And they're asking about diet, and essentially we don't know much, but there seems to be a strong link between obesity and risk of psoriatic arthritis. So I tell them that likely maintaining a normal weight is a way to potentially reduce the risk of developing psoriatic arthritis. We don't have any trials yet, but there seems to be some data to suggest that people that had bariatric surgeries, for example, and were able to reduce their weight, were at a lower risk of developing future psoriatic arthritis. What about cholesterol? So cholesterol can be divided into good cholesterol and bad cholesterol. The bad cholesterol is called LDL, low density lipoprotein, and this cholesterol is the type of cholesterol that accumulates in the blood vessel wall and creates the plaques that eventually block the blood vessel or rupture. HDL is the good cholesterol, and that's the type of cholesterol that brings the cholesterol from the blood vessels into the liver and out of the body. So when we talk about cholesterol, we need to make the distinction between the good and the bad cholesterol. And this is important because when people are asking what is a normal cholesterol, it's really hard to say because the guidelines are complex, and they really depend on your future risk of developing heart disease within the next 10 years. And this is very different if we consider someone who is young and has no other risk factors compared to someone who is older and smokes and they have diabetes. So the level of normal cholesterol in these two individuals is very different, and the question whether they need to take something or medication to reduce their cholesterol depends on their risk of developing heart diseases in the next 10 years. So the guidelines tend to change. In fact, these are already outdated. There are newer guidelines, and it's a good idea to consult the family physician or another specialist to check whether there needs to be any intervention in terms of changing the cholesterol. So what is blood pressure? I'm sure you all know what blood pressure is. So essentially, blood pressure depends on the heart pumping, and when the blood pressure is stretching the blood vessels too much, it means that the blood pressure is high. It can cause damage to the heart, the blood vessels, the kidneys, and the brain. And when we measure blood pressure, there are two numbers. The higher number is called systolic pressure, and this is the pressure when in your blood vessels when your heart beats. And the lower number is the diastolic pressure, and this is the pressure when your heart is at rest. So what is a normal blood pressure? Again, it depends. So for most people, blood pressure of less than 140/90 is considered fine. And this is especially in the doctor's office when people tend to be a bit more nervous. When you measure it at home, usually the recommendation is to have a blood pressure of less than 135/85. And for people with diabetes or a kidney disease, the blood pressure should be less than 130/80. And it's always a good idea, again, to consult with the family physician and check what is the appropriate blood pressure level for you. Diabetes, as you all know, is elevated blood sugar, and it can affect multiple organs. It can affect the heart, the kidneys, the eyes, the nerves. And diabetes has been strongly associated with both psoriasis and psoriatic arthritis. We've conducted a study again in our clinic where we compared the prevalence of psoriasis over the past 20 years in patients in our clinic compared to the general population in Ontario. And you can see in this graph that overall the prevalence of diabetes has increased over the past 20 years in both the general population as well as in the patients with psoriatic arthritis from our clinic. But at all times, patients with psoriatic arthritis had higher levels of diabetes compared to the general population. And the overall risk is again about 40% higher compared to people at the same age, at the same sex, who do not have psoriatic arthritis. So what sorts of tests we might do to investigate for these traditional risk factors that are associated with heart diseases? So these are tests that we either do in rheumatology clinic or family physicians typically order, but it is recommended because of the high prevalence of these traditional risk factors to do these tests at least once every 5 years, and in older people at least once a year. So we're talking about cholesterol or lipid tests, tests for glucose levels or sugar for diabetes. And we also often check markers of inflammation. And this is important for us to know how active the arthritis is. And it also provides information about the future risk of developing heart diseases. Blood pressure can be measured at home with these home machines that are pretty reliable. But if measurements tend to be higher, towards the higher level, then sometimes family physicians or cardiologists order these 24 hours blood pressure monitoring, which tend to be more accurate and give an accurate picture about the changes in the blood pressure over time. So these traditional risk factors, diabetes, blood pressure, cholesterol, they can be managed with some lifestyle modifications, especially changes in diet, weight loss, and exercise. But sometimes it's not enough, and there is a need for medications. And it's always a good idea, again, to consult with a family physician or a specialist. Many people are asking about diet, and many of my patients are asking what they should eat or shouldn't eat in order to help with their psoriasis or psoriatic arthritis. And it's really hard to answer because there are not, although there is a lot of websites that claim that certain foods are good for the skin or for the joints, there's really no hard data or hard evidence to suggest that certain diets are better than the other. But we do know that some diets, especially DASH diet and Mediterranean diets, are generally good diets for the heart and the general health. And I do recommend these diets because of the connection with cardiovascular diseases and the fact that they contribute to general health. So they certainly probably would not hurt the skin and the joint activity. These diets are based on fresh products, so fresh fruits and vegetables, lean fat, and especially fish and chicken, preferences, reduced in salt in the diet, and low-fat milk products. Generally, processed food is not recommended. This is any processed food or fast food is really not something that we should consume on a daily basis. And there are some information that we can get from food labels, so it's kind of a good idea to start checking these. And generally, I just wanted to highlight this sodium percentage in the diet. Everything that is less than 5%, this is the daily value, is considered to be good. More than 15 is bad. So quick check before consuming these high salt products. What about exercise? So exercise is really a very powerful medication. It's exercise is medicine, and it's been consistently shown to be helpful for many conditions, from heart diseases to diabetes and weight control, and reduce risk of cancer. And it also helps arthritis. And many people who have arthritis have difficulties exercising because of their joints, that they are painful, and they're also concerned that exercises may make their arthritis worse. And in fact, there are many studies that have shown that over a long period of time, people who exercise and are able to exercise on a regular basis have reduced pain or able to reduce the levels of pain through exercise. And there are certain strategies to address joint pain in people who are starting to exercise, and it's really very important. Smoking is a known risk factor for psoriasis, and smoking cessation is certainly recommended. It's bad for psoriasis. It's bad for many other medical conditions. So And there are now smoking cessation programs and ways to help people who are interested in smoking cessation. And finally, this is something that we don't talk a lot about, sleep and health, but poor sleep has been associated with cardiovascular diseases and with obesity and diabetes. Good sleep hygiene is really important. So there are some conditions that may lead to sleep disturbances. Obstructive sleep apnea is one of them, and it may cause abnormal sleep pattern and may lead to fatigue and increase the risk of future heart diseases. So poor sleep can be managed, and it's again recommended to consult the family physician if you are experiencing unrefreshed sleep or frequent awakening during the night. So really, we're talking about healthy lifestyle choices. These are things that are under your control and you can change. And I know it's really hard because I mentioned a lot of things, but really the goal is to take one step at a time, replace unhealthy habits with healthier ones. So if you focus on diet, focus on changing few things in your diet rather than counting calories, and start exercising. So start slowly, 10 minutes a day, and increase gradually. Pick a type of activity that you think you can stick with for a prolonged period of time. So these are important things. And also think of it as lifestyle changes. These are not quick fix. These are things that should, it's really hard to adhere to these things, but try to change things that you can think you can stick with. Pick a friend or a family member to do these activities with, and forgive yourself if you're, you skip one day or you're unable to stick with some of these things, and reward your successes. So I just want to quickly mention our program at Women's. We have a program, cardio-rheumatology program, that is open to patients with rheumatic conditions. We do accept external referrals. So if you do have a diagnosis of rheumatoid or psoriatic arthritis or ankylosing spondylitis, and you're interested in assessing your heart condition, this is something that's open. So to summarize, psoriasis and psoriatic arthritis are associated with increased risk of developing heart diseases. Control of inflammation in the skin and the joints can reduce the risk of future heart diseases. And management of risk factors such as cholesterol and diabetes, either through healthy lifestyle or if needed by medications, is really important to reduce future cardiovascular diseases. So this is our team at Women's College Hospital in Toronto. And I just briefly wanted to highlight that we are studying now the effect of diets on patients with psoriatic arthritis. So this is again a study that is open for people who are interested. Please feel free to contact us. This is the name of our study coordinator. Thank you for your attention, and I'm happy to answer any questions.
That was fantastic. Thank you so much, Dr. Eder. And if anyone does want any information about the study that you put up here too, you can always get in touch with CPN, and we can definitely share information. Thank you both so very much. I really love that we wrapped it up with the summary of kind of how to take these steps, because we've crammed in a lot of information, great information, in a short amount of time. So it can feel overwhelming to hear about all of these, associated conditions and elevated risks. But the awareness is power, and I think just these continuing to have these conversations. CPN is a source of information. We have resources on our website about diet and psoriasis. We did a webinar that took a deeper dive into that area, and also information about good sleep hygiene, eating well, and all of those components that really make up a good, healthy life, regardless of if you live with a chronic condition or not. So thank you so much. I think that was very, very helpful to kind of wrap up the conversation, especially this type of conversation. We do have a couple of questions going, so we're very fortunate that we can have both Dr. Kirchhoff and Dr. Eder provide answers from a dermatologist and a rheumatologist perspective. One of the first question I received is about conditions with the eyes. The specific question is dry eye syndrome a condition related to psoriasis or psoriatic arthritis? And I know that uveitis is an inflammatory condition of the eye that we often hear is a comorbidity. I wonder, maybe we can start with Dr. Kirchhoff and then to you, Dr. Eder, if you have anything to add about conditions associated with the eyes.
So I may not be the expert because so Sjogren's syndrome, for instance, is a rheumatological condition that we know is an autoimmune disease. And as I mentioned, people with one autoimmune disease are at higher risk of having another autoimmune disease. So and that is, that can be manifested by dry eyes. So I would say there is a risk. In terms of general dry eyes, I'm not sure, because it's a multifactorial process, and it would be hard for me to say that all dry eyes are related to psoriasis, but I would definitely say it is possible, and there are conditions where we know there are potential associations.
Great. And do you have anything to add, Dr. Eder, to that before we go to the next one?
Yeah, I agree. I think Sjogren is definitely one of them, although probably the less common cause of dry eyes. Dry eyes is a symptom. It's very non-specific, so it's a good idea to see an ophthalmologist, because there are objective tests that they do, and depending on the degree of the dryness, they could recommend ways to deal with it, regardless if it's Sjogren or something else. So.
Okay, great. And then the other question that I think it might be for you, Dr. Eder, is does psoriatic arthritis affect the fingers? Can you speak a little bit about that and how hands are affected?
Oh, yeah, certainly. So psoriatic arthritis can definitely affect the fingers. In fact, so psoriatic arthritis can affect any joint, essentially. It can affect the fingers, it can affect the toes, it can affect the spine. It can also affect the tendons. The fingers is one of the more common areas that psoriatic arthritis can affect, and it can affect one joint or multiple joints, and typically the joints will be swollen. They will appear swollen. Sometimes they will look like a sausage, so that would be dactylitis. That's another typical manifestation of psoriatic arthritis. And it will be painful typically. So, yeah.
Great, thank you so much. If you have any other questions, we invite you to put them into the chat. I'm getting them in kind of a couple of places here. So one question that I think is really helpful to hear from you both is how do specialists work together to support a patient? So if you're, we ideally would love to see like wraparound care. I think there's a couple of examples of good dermatology, rheumatology clinics. But in cases where, a cardiologist is involved and potentially an endocrinologist, any insights into, how you support your patients as part of that kind of interdisciplinary team that might be helpful to hear? Maybe Dr. Kirchhoff, if you have any.
Oh, all right, sure. I think Dr. Eder probably has a very unique clinic, probably in the world, I would say. So I have perhaps a much less rosy picture. I think, unfortunately, medicine is very siloed. And in my experience, often, one specialist will do something and send a letter off to another specialist, or at most give them a phone call and then discuss a patient. But really, true interaction, true coordination between specialist care, I think, is still one thing that is lacking largely across the country and the world, in fact. And so I think that there is lots of room for improvement in that regard.
And so with that, can you maybe tell us a little bit about your clinic and the benefits of that kind of a model, Dr. Eder?
Yeah, so our clinic was, in fact, it is a unique program, although there are several cardio-rheumatology programs now around the world, but we, as far as I know, were the first in Canada. So we are very fortunate that we teamed up with the cardiologists that are interested in rheumatic diseases. And we know that essentially all of the rheumatic diseases are associated with a high risk of developing cardiovascular diseases. So the idea is prevention. So we want to identify people before they develop all of these problems and find ways to identify these people earlier by doing special imaging tests or special blood tests. And we also want to educate our colleagues, because many of our colleagues, especially family physicians, are less aware of this connection between cardiovascular diseases and rheumatic and diseases, as well as some of the dermatology condition. I realize that this is a luxury of working in an academic center, and I know that many people that work in community or remote population or remote areas do not have this luxury of having combined clinics. But one take-home message maybe for the people who listen to us is that I think awareness is among patients, and being their own advocates is really important. So when they are aware that they are at high risk, then triggering and initiating the conversation with a family physician is really important.
Mm-hmm. That's a great point. And I think especially, you mentioned a couple of tests, like checking cholesterol and sugars, which may not happen necessarily in every situation, but knowing that, and I would add to the earlier presentation as well, the mental health piece, and just bringing that up as as something that if you don't bring it up, it might not come to the surface as often as some of these other screenings. So that's really useful to keep in mind. Thank you. And then another question that if we can talk a little bit more about treating the conditions and how that there might be some potential for mitigating some of these comorbidities, right? And by treating psoriasis, there's emerging research that is looking at how that affects potentially reducing risks related to cardiovascular disease. Can you talk a little bit about, like, where is the research on this? Is it something that, or is more research being done, or is this, do we accept this as kind of a well-known or confirmed in research that there is that relationship between treatment and reducing risks? Dr. Kirchhoff, I don't know if you wanted to talk a little bit about that. You were talking about methotrexate and TNFA in particular, and I wonder if you can speak to the research a little bit more. Well,
again, I'm by no means, I think Dr. Eder is much more versed in some of the research, but I can tell you that I mean, without muddying the waters, it is much more complicated than it at first appears. The meta-analyses that have been done with patients who are on treatment were actually, as you saw in the data that was presented, were positive. There was a large study that was undertaken with methotrexate where they tried to prevent cardiovascular disease, and unfortunately the trial was not successful. Now they've done sub-analyses and say, well, maybe in a certain population it still has a place and it's still important, but and then there's been several biologics that have been used to try to see if they could have anti-cardiovascular disease properties. And again, the data has been somewhat mixed. There were Dr. Joel Gelfand is one of the big proponents of this in the United States, and he's found that sometimes, you know, there are biologic agents that do seem to have some minor impact, and others that seem to have none at all. And so I would say we are still confused and still trying to really sort out what the reality is. I would say from a pathological or pathophysiological standpoint, it makes sense to reduce inflammation, and that would have a positive impact on cardiovascular disease, obesity, other outcomes as well, psychiatric outcomes as well. So from a pathophysiological standpoint, it makes sense. And some of the data from real world trials and meta-analyses seem to support this, but there are other pieces of data that question it. And so I don't think we have a completely defined or clear answer yet.
Would you agree, Dr. Eder? I kind of keep starting with the first speaker, so please jump in.
No problem. I think that's a great summary. We are confused. So I think there is good data, and in rheumatic diseases and in psoriasis, I don't think it will be ever possible to do a big trial to know for sure if a biologic is protective for heart disease, because it wouldn't be ethical to leave patients without treatment for such a long time. So I don't think we'll know the answer for sure. But from the data that we have, at least, and I'm talking about rheumatological diseases where methotrexate has been investigated extensively, and with TNF inhibitors that's been around for more than a decade now, at least there is observational data to support this, as I've shown. And this is certainly just another addition to why we should reinforce these treatments. And in rheumatology is a bit different than dermatology in a way that we kind of have irreversible effect of inflammation on the joint. So inflammation, uncontrolled inflammation in a joint will cause a destruction of a joint. And in psoriasis, usually you can reverse the effect with treatment. So we tend to be we don't like to see any inflammation, and that's kind of another reason why we kind of try to control these things. And the cardiovascular effect seems to make sense, and it's another bonus.
That's fantastic. Thank you. And that is something, the question comes up a lot, and so you both have made it clear as to why, because it is something that we understand to a certain degree and may never fully understand because of the limitations that you mentioned, Dr. Eder. But I think, again, it was very helpful to see the research that we do know presented by you both, so thank you, because it gives us some idea of what we do know. Another question that comes up a lot is in terms of psoriatic arthritis and psoriasis and treating the conditions. Do we, like, I can start with you, Dr. Eder, this time for sure. In terms of treating both conditions, who usually, would it usually be a rheumatologist who a person would be seeing regularly and would be treating both the conditions if you're living with psoriatic arthritis?
Again, it depends. So we talk about personalized medicine. This is a personalized medicine. If someone would have a very small plaque and very severe arthritis, and I'm initiating a systemic medication to treat their joints, it's likely going to help their skin. Sometimes I would prescribe a topical cream if I feel like if the plaques are very mild. But certainly if someone has psoriasis that is either very widespread, or if it's affecting very sensitive areas like the genital area, or areas that are harder to treat like the scalp or the palms, then I would strongly advise or refer them to one of my dermatology colleagues, and that will be, we co-manage, and we often discuss patients' care and selection of medications, because we know that some of the newer drugs might work better for the skin than for the joints and vice versa. So it's really important to coordinate care if possible.
Great. And that's actually another one that we encourage people to mention to their dermatologist. Often people with psoriasis who eventually experience psoriatic arthritis will have joint pain for a long time before they mention it to their dermatologist. So I think that's a really important point when we're talking about associated conditions, since about 1 in 3 persons with psoriasis will be estimated to develop psoriatic arthritis. So looking at the time, there are no questions coming in right now. We've wrapped up the questions that we did get. So I wanted to take a minute to thank both of our speakers again before we wrap up for tonight, and to tell anyone who has outstanding questions or any questions that come up, you can always email CPN. Again, we're at cpn-rcp.com, and we'll do our best to follow up on any questions that occur to you after this event. In the meantime, again, if you're interested in the study that Dr. Eder mentioned in regard to diet and psoriatic arthritis, you want more information, you can also let us know. And with that, I do want to thank you both so much for your expertise, your presentations, and again, making us feel like there are things people can do and there's actions to take, and knowledge is the first step. So we greatly appreciate you sharing yours, and we hope to have you back for future presentations. And thank you again for tonight.
Thank you.
Thank you. Have a good night.
Bye.
Take care.